Good evening. Across our city, there is a quiet transformation taking place inside our hospitals, not driven by new machines or new miracle drugs, but by people. People who once sat on the other side of the crisis table and who today stand shoulder to shoulder with clinicians, and we're called peers. And in places like Toronto, at UHN, in partnership with TNG, which is the University Health Network, in partnership with the neighborhood group, my employer, our impact is not just meaningful, it is measurable. The numbers tell the story. In Canada, between 15 and 20% of all emergency room visits are driven not by new medical emergencies, but by unresolved social, psychiatric, and addiction related barriers. Every repeat visit costs the system hundreds of dollars. In a province where frontline staffing is strained and the government under Doug Ford has approved billions in healthcare reductions and restructuring, the old system simply cannot absorb that burden anymore. So the peers have entered the story. Peers are people who have lived experience of trauma, addiction, homelessness, or acute mental health crisis and return to steady ground. At the University Health Network and the neighborhood group, I meet and work with peers who now walk the same hallways, we all once entered scared, angry, or alone. Today, we meet patients in the ER, in waiting rooms, and in transitional care spaces before those patients fall through the cracks again. And the cost savings are unreal. When a peer successfully engages someone who would otherwise cycle through the ER 3, 4, or 5 times in a month, the taxpayer is spared thousands of dollars in clinical time, ambulance use, diagnostic testing, bed occupancy, and staff burnout. One Ontario evaluation found peer support models reduced repeat ER use by up to 30% among frequent visitors, a shift that ripples through the entire system. Doctors and nurses at the University Health Network told me bluntly they cannot do this alone. With staffing shortages, double-booked surgical schedules, and provincial cutbacks, they are legally and clinically responsible for care, but they are not equipped to navigate social collapse. That is where peers step in, not instead of professionals, but alongside them, translating crisis into conversion, fear into compliance, and isolation into trust. A senior emergency physician put it this way: a peer can get a yes from a patient in 3 minutes that would take me 3 hours or never. And I saw something else, the human return. When a cold clinical room becomes a place where a frightened patient hears, "I've been where you are," you can see a face change. You can see shoulders drop. You can see sometimes for the first time in years a person believed they are not a lost cause or a lost case. The peers I met at UHN and TNG were not just competent, we are taken seriously by physicians, trusted by nurses, and relied upon by overwhelmed social workers. They are stabilizing forces in a destabilized system. Some of the most seasoned staff told me they now count on peers as much as any instrument in the clinical toolkit. And there is a second miracle here. The peers themselves to witness someone return to the very institution that once treated them. But now, as a colleague, a contributor, a taxpayer again, is to watch public policy succeed at its highest moral and economic level. Every peer who stays stable, working, and housed is a taxpayer, gained, and a system burden reduced. In an era when governments speak the language of efficiencies while cutting the very budgets that keep services alive, the peer model is one of the only solutions that both saves money and saves people at the same time. Programs like the University Health Network and the Neighborhood Group Partnership are not ornamental. They are essential infrastructure for a province under stress. The data proves it. The staff confirm it. The patients feel it. And the public treasury benefits from it. At a time of shrinking budgets and rising need, this model is not a charity. It is a necessity. It protects doctors, it preserves nurses, it honors social workers, it rescues patients, and it returns dignity to people once written off by society unfairly and unnecessarily. If Ontario wants to keep its hospitals open, its professionals upright, and its taxpayers protected, it cannot afford not to invest in peers. Thank you for listening and have a pleasant week.